dear participants, listeners, ladies and gentlemen. On behalf of the Student Scientific Society of Medical University of Silesia in Katowice, I'd like to thank you for coming and taking part in International Medical Congress of Silesia 2025. My name is Małgorzata Toruń, and I have an honor of moderating session of Anesthesiology, Intensive Care and Emergency Medicine. I would like to cordially welcome the esteemed jury, the president of the jury, MD, PhD Łukasz Czerwik. Piotr Czerwik. Dr Michał Kurka. Dr Agnieszka Biurek. We would like you to explain the rules of the session. The order of the presentation will be the same as in the abstract book. The maximum time for the presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on to conclusions and finish the presentation as soon as possible. Esteemed jury, I'd like to kindly remind you that if you are the supervisor of the paper which is presented to you, should not assess the work. In that case, please cross out the number on your card. All members of the same clinic are able to assess the presentation. The assessment will be verified. I'd like you to remind you that if the work is presented in English, the discussion also should be run in English. If the commission will ask the question in Polish, the authors of the work are obliged to answer them in English. We kindly ask the jury to assess scientific value from 1 to 5, then way of the presenting from 1 to 5, discussion from 1 to 5, and own contribution from 1 to 5. When the session ends, we kindly ask you to give the cards back to the coordinator. To begin, I think we can start from the first presentation, which is presented by Victor Wagner. The work titled Metabolic Disorders During Continuous Renal Replacement Therapy. The floor is yours. Brawa dla pierwszej organizacji.
So, talking about metabolic disorders, we usually focus on acidosis. Acidosis this, acidosis that, but aren't we forgetting about something? Dear scientific committee, dear colleagues, welcome. My name is Victor Wagner, and I would like to present to you the fruits of my and my colleagues' labor in a form of presentation, metabolic disorders during continuous renal replacement therapy under the supervision of Professor Łukasz Czerwik. A short introduction about the therapy itself. We, in this work, will mainly focus on two aspects of the whole renal replacement therapy. The dialysate, which is a fluid which flows through the body and takes out the toxic metabolites, as well as then some kind of anticoagulation, here, citrate. The most common cause of introducing continuous renal replacement therapy is acute kidney injury. And about 40% is pre-renal, mainly sepsis and sepsis shock. The citrate, which is the most commonly used regional anticoagulation, is a weak acid. One of the important things about it is that it can accumulate in human body. As for its anticoagulation, it binds calcium ions, creating CCC, a complex, thus inhibiting the coagulation process. It cannot happen without the calcium. And what is crucial for the future part, in anticoagulant solutions, it usually exists with free sodium ions, which makes it deliver a lot of sodium into the patient's body. And the most common complication of the therapy, which I will focus in the future part of the presentation, is acid-base balance disturbances, acidosis and or alkalosis. The aim of our work was to assess if the occurrence of acid-base disorders and to compare it with usage of citrate anticoagulation. What is more, we tried to investigate the possible connection with liver function and if the therapy hurts the liver. We constructed a group containing 89 patients from the January to December 2023 who received continuous renal replacement therapy. Data were retrieved from medical records, mainly AMS and from the paper. Analysis of correlation was done with Spearman correlation test using PRISP software, and the main graphics were done in Excel software. And as for the results, we retrieved that 89 patients received continuous renal replacement therapy, and 1/3 developed some kind of metabolic disorder. However, 25 patients had present liver injury, which occurred before the therapy. However, all of the patients received some kind of hepatotoxic drug, mainly antibiotics used to treat sepsis. The group contained of 17 men and 14 women. The mean and median age was about 61 years. The group with the disturbance, 33 patients. 4 had sepsis, 11 had right ventricular failure, 12 had both sepsis and right ventricular failure, and only 6 patients haven't developed any of those. This group, as we see, is heavily, has some really important medical problems. And as for the results, 80%, 26 patients, very big group, developed alkalosis, which is not as present as acidosis maybe in scientific papers. The mean time of appearing of the disturbance was the 8th day, and the median was the 5th day, which is pretty early during the therapy. The metabolic disorders, we compared the volume of dialysate in milliliters per kilogram of body weight with a lot of heparin tests, including albumin, total protein, aminotransferases, and fibrinogen. And as we see, there was no correlation, and we couldn't make it statistically important. However, the volume of dialysate correlated negatively with deviation from pH norm and with INR, positively with INR. And for the conclusions from our work, alkalosis is the most common metabolic disorder, and it happens mainly in the first days of therapy, which means we need to monitor the patient closely, especially in the first days of therapy. Dialysis volume correlated with pH disturbance size and INR. However, it did not correlate with liver condition. According to the literature, the pH norm disruptions can be managed by making the dialysate flow bigger, and it is in compliance with our findings. The bigger the dialysate volume was, the smaller the pH disturbance were. The liver damage often exists before the therapy, but the therapy itself does not worsen its condition. It can be seen by the lack of any correlation between the volume of dialysate and the liver tests. The usage of citrate as an anti-regional anticoagulation during the CRRT is a valid and tested method. And lastly, coming back to the sodium ions, which can be present in citrate used in the therapy. The amount of the ions can be important if we're assessing the pH disturbance with the Stewart's model, which can be discussed and thought about in a future work in ICU. Take-home message: the alkalosis in notoriety. It exists, and it's a real common problem in group of patients receiving CRRT. These are the references we used, and thank you very much for your presentation, and I'm looking for any and all questions.
Thank you very much for your presentation. Are there any questions from the jury?
Just a question, because you showed that the alkalosis is quite common during CRRT or citrate. Do you have any ideas how to avoid it?
Yes, there are a few ways we can prevent from the developing of alkalosis. Firstly, with managing the CRRT by increasing the dialysis flow, as I said in the presentation, as well as lowering the blood flow, which can be beneficial. What is more, we can possibly try to compensate the metabolic alkalosis with a slight respiratory acidosis, which can be done by changing the respiratory rates. What is more, when the problems with too much of citrate, an accumulation of citrate, which is the problem why the alkalosis happen, we can try to stop using the citrate for a moment. It can make the ports used for CRT last shorter and needs to be replaced. However, thus it can prevent the alkalosis from happening.
Other things that in conclusions you stated that liver damage is not a contraindication for CCRT on citrate. Could you comment on that?
Yeah, thank you very much. The very heavy liver damage can be a contraindication for citrate, but however, researching the huge meta-analysis, the most patients with hepatic damage weren't, it wasn't contradiction because about 60% of citrate with calcium is filtered by the filter in the CRT machine. So the about 40-30%, which must be metabolized by the liver, usually the liver status is good enough to metabolize this small amount of citrate, which is coming back to the patient's body.
So is there any cutoff of the liver injury above which we shouldn't use citrate? I mean, citrate is the most common way of carrying the anticoagulation, yes? Because it's efficient and it saves the life of the filter. But could you just tell us at which level of liver dysfunction we should forget about citrate?
When we were researching through our group, only one patient had a really enormous liver dysfunction with aminotransferases level above thousands, and this patient had stopped receiving the citrate. If I had to conclude the cutoff level, it needs to be further researched. However, novel studies direct that use of prostacyclin as a regional anticoagulation can be beneficial to patients with heavy liver injury.
Congrats on your presentation. And I would like to ask you, because you emphasize on the use of citrate and the risk of accumulation. And do you know, because in most equipment, most devices for continuous renal replacement therapy, we can adjust the dose of citrates that we administer to the patient. Do you know how in the daily practice we determine the flow rates, the rate of the infusion of citrates?
Yes, as for the obviously the metabolic disturbances, including pH and other including pH, are tested about every 8 hours in the ICU unit, and assessing the disturbance we are occurring. We're trying to, as I said, we can lower the blood flow, lower the blood flow or increase the volume, which is done in the machine. But most important, the monitoring of the patient, the constant monitoring of the patient, which can help us see maybe see the future, see what can happen.
Okay, you were referring to the pH adjustment. However, I referred to calcium concentration. Yeah, because we monitor calcium in both arterial and venous blood, and that's sort of an indication for us how much of a flow rate we should adjust, right?
As the citrate main reason we are using citrate is because it binds calcium, which inhibits the coagulation process. there are used some kind of calcium to ionized calcium rates are used to assess. Like I was
usually ABGs are enough.
right.
But it's very important to remember about that because if we forget, it may severely shorten the life of the filter we're using, of the set CRRT we are using. Right?
Hypocalcemia is also a problem which can occur during the therapy, so it needs to be closely monitored.
Thank you.
Thank you very much for your presentation. I also would like to welcome Professor Łukasz Krzyk and ask if everything is okay, if we can hear each other.
Dzień dobry, witam Państwa bardzo serdecznie. Hello guys, thank you for this possibility to join you during the session, and I hope that everything will be okay with you and your presentation. I keep the fingers crossed.
Thank you.
May I ask to turn off the microphone because for the present? Okay, thank you.
So because we have to give points for creative own contribution. So let's say everyone at the end of the presentation says what was his contribution. That's why we don't ask.
Okay.
Yeah. So what was your contribution?
So Victor, could you say what was your contribution in the work? Okay.
But I can quickly text him and ask him.
Okay, so Victor will come back and
Then
he will say what was his contribution. Okay, so I think we can move on to the next presentation, which is the influence of vasopressors and introps on patient during digoxin intake, presented by Emilia Sławojska. The floor is yours. If you also have the time.
So good morning, ladies and gentlemen. My name is Emilia Sławojska, and today I'm honored to present you a scientific paper based on a retrospective research study that me and my colleagues conducted at the Department of Cardiac Anesthesiology and Intensive Care at Faculty of Medical Sciences in Zabrze. Our study is focused on digoxin, which is a cardiac glycoside of natural origin. Its mechanism of action is the inhibition of sodium and potassium pump in cardiac cells. This results in increased sodium concentration within those cells, which further leads to improved cardiac output and heart muscle contractility. Thanks to its mechanism of action, digoxin is primarily used in treatment of heart failure and is also utilized in management of supraventricular arrhythmias, such as atrial flutter and fibrillation. The primary objective of our study was to assess whether vasopressors and inotropes have effect on digoxin levels and doses. To achieve this, we gathered data from intensive care unit database at Silesia Center for Heart Diseases in Zabrze. Out of 980 admissions from January 2018 to July 2023, we selected 103 patients. All these patients received digoxin, as well as other medications such as epinephrine, norepinephrine, dobutamine, levosimendan, milrinone, and vasopressin. In our study, digoxin dose is expressed in milligrams, and digoxin level is expressed in nanograms per milliliter. Our statistical analysis revealed that p-value for each of those medications was greater than 0.05, indicating there was no statistically significant difference in digoxin level and dose when combined with those medications. However, an interesting finding emerged regarding mortality rates. In the case of epinephrine, mortality was at 52.3%, and in the case of vasopressin, the mortality rose to 65%. Both of those medications had p-value below 0.05, indicating a statistically significant difference. We also discovered that patients with liver failure had higher digoxin level, reaching 1.31 nanograms per milliliter, while patients without liver failure had digoxin level at 1.06 nanograms per milliliter. Furthermore, we observed that patients with respiratory failure had higher digoxin dose, reaching 0.210 milligrams, while patients without respiratory failure had digoxin dose at 0.145 milligrams. Our statistical analysis also revealed that women required smaller doses of digoxin compared to men. The mean dose administered to women was 0.171 milligrams, while in the male population it was slightly higher, reaching 0.224 milligrams. Lastly, we prepared a short slide containing the most important information from our presentation, which are as follows. Vasopressors and inotropes do not significantly affect digoxin levels or doses. The administration of epinephrine and vasopressin during digoxin therapy may be associated with increased mortality. Liver and respiratory failure can influence both digoxin levels and doses. And lastly, women typically require smaller doses of digoxin compared to men. This brings us to the end of the presentation. Thank you for your attention. And if you have any questions, feel free to ask them. Here are the references. That's it.
Thank you very much for your presentation. Are there any questions from the jury?
Zapytam polską, ale odpowiedz po angielsku, proszę, dobra? Musisz nas bardzo mocno przekonać, dlaczego powiązaliście temat wazopresorów i inotropów w jednej grupie, i wazopresorów i inotropów z digoksyną. Czemu to miałoby mieć związek ze sobą? Czemu na przykład pacjenci otrzymujący wazopresory mieliby mieć inne stężenie digoksyny? Jaki jest mechanizm patofizjologiczny tego? Możesz nam coś powiedzieć więcej?
So generally, the idea for this work was to verify that because all the patients in the ICU receive multiple medications, which includes digoxin and vasopressors and inotropes. So that's why we consider that as a
pathophysiological link. My colleague meant pathophysiological link. Yes, what was the hypothesis? Because when you start analyzing anything, you need to have some preliminary hypothesis, you know?
Mm-hmm. I understand, however, I don't think I can explain that right now since I don't know how to do it in English. So, maybe try in English.
May I have a question also?
Okay.
Can you hear me now or no?
Yes, I can hear
Okay.
you. I see you, so
For me as well, the rationale for the study is unclear. Maybe it would be easier for you if you give us some indications for digoxin use in your group of patients. So, what was the reason for digoxin use in your patients instead of amiodarone, which is the first line treatment? So, how many patients received amiodarone as well? How many patients had any contraindications for amiodarone use? This is a very specific group of patients that receive digoxin in modern intensive care medicine and perioperative medicine. Could you explain it in more detail, please?
Okay, so we selected patients who had heart failure, which was the main indication of usage of digoxin, as well as the other medications. Those patients were selected only with the heart failure syndromes or heart failure in general, hence the use of digoxin and the other medications as well. We excluded patients without heart failure, and I think I sort of answered the question. I don't know where to look, but I guess that's the answer for my question.
I can't hear you, in fact. Did you exclude patients with heart failure?
We included those patients in
You-
our group, which is.
I hope so. That's the main indication to treat in cardiac center was heart failure. However, the second question was about contraindications for amiodarone use and how many patients received amiodarone before digoxin T treatment, or it was a concomitant treatment.
I don't have data about patients who received amiodarone. We focus mostly on the digoxin.
Thank you.
Also, the last question, what was your contribution?
So my contribution was to create the presentation, create a text for the presentation, and also with all the entire group, we together brought the conclusions from the statistical data we gathered.
Thank you very much for your presentation. And now let's move to the next presentation, which is assessment of Polish anesthesiologists' preferences for pharmacotherapy during RC SRA study, presented by Dr. Stefan. The floor is yours.
Good morning, everyone. My name is Dr. Stefan, and together with Paulina Motyńska, we are pleased to present the findings of our survey study concerning preferences of Polish anesthesiologists for pharmacotherapy during rapid sequence intubation.
So, because of technical problems, I'd like to welcome our next jury committee. Dr. Ewa Trojanowska is with us. And also Victor is unfortunately not with us, but I have the message from him. What was his contribution? So he said that he analyzed the data, he also collected the data, he prepared the data, he also was responsible for the aim of the work and also the bioethic commission. Okay.
We can start again from.
So once again, good morning, everyone. My name is Dr. Stefan, and together with Paulina Motyńska, we are pleased to present the findings of our survey study concerning pharmacotherapy during rapid sequence, which is used by Polish anesthesiologists. Rapid sequence intubation is the procedure which is performed in patients who are unfasted or at risk for aspirations and who require instrumented airway protection. In our survey, we asked respondents which drugs and at what doses they would use in the hemodynamically unstable patients, because in this group of patients, the demand for anesthetic agents changes because the risk of peri-intubation cardiac arrest is higher.
The mic is not working.
Okay, so there are two classes of drugs used during RSI. The first one is intravenous sedative hypnotic agents like propofol, etomidate, and ketamine. And the second is rapid onset neuromuscular blocking agents like glucuronium or succinylcholine. There is ongoing debate regarding the selection of the optimal drug. So, like I say, there are no clear guidelines concerning the RSI procedure, but current meta-analysis shows that ketamine may be more beneficial than etomidate, increasing the survival of the patients, especially in the group of critically ill patients, because even the single dose of etomidate can induce adrenocortical suppression.
Mogłabym poprosić o ten mikrofon?
This is not the only uncertainty according to drugs using in the RSI procedure, and that's why we conducted a study to check which induction agents and in what doses are used by Polish anesthesiologists. The survey consisted of 13 single choice questions and concerned the choice and dosage of the anesthetic and muscle relaxants. The responses were collected electronically, and the invitation was sent to over 500 anesthesiologists. We received 166 responses. 60 was from specialists, and 106 was from doctors undergoing specialization. The participant verification was performed at the point of admitting patient to the online professional community group from which the survey was distributed. The verification relied on National Register of Doctors and on each physician's specialty certificate. So let's now proceed to the results of our study. Among the survey respondents, ketamine is definitely the most frequently chosen sedative hypnotic agent in hemodynamically unstable patient. Propofol is in the second place, and etomidate in the third place. Midazolam was chosen only by 2 participants. The most frequently selected dosing range of ketamine was between 1 to 2 milligrams per kilogram of body weight, with 1 milligram being the predominant choice. In the case of etomidate, anesthesiologists selected both the minimal and the maximal recommended doses, irrespective of information about the patient's hemodynamic instability. It is worth noting that in our survey, propofol was the second most common chosen drugs, and it was the most often it was administered at a dose of 1 milligram per kilogram of body weight. Among our respondents, the majority use neuromuscular blocking agents during the RSI. However, there are 16% of doctors that declare that they would not use such a drug. As you can see, succinylcholine and glucuronium are selected with roughly equal frequency. However, succinylcholine is chosen slightly more often. And the most commonly chosen doses of succinylcholine is 1 or 1.5 milligram per kilogram of body weight. And in the case of the glucuronium, the most frequently chosen dosage is 1.2 milligram per kilogram of body weight. To conduct our presentation, ketamine in reduced dose and succinylcholine, that's our mistake on the presentation, sorry for that, are both often used for RSI in the unstable patients. Moreover, the common discussion about choosing the anesthetic drugs in RSI usually centered about etomidate and ketamine, but our survey shows that Polish anesthesiologists more often use propofol than etomidate. And our second conclusion is that despite the recommendations, there are some doctors who don't use neuromuscular. Thank you for your attention.
Thank you very much for the presentation. Are there any questions? The microphone is still on.
The mic is always on. So, my question is about it's working.
It's working.
The pathway has been changed for the first, these patients were hemodynamically unstable, all of them. Am I right?
Yes, the survey was about what drugs would an anesthesiologist use when the patient is hemodynamically unstable.
And it requires RSI.
Yes.
Okay. So first of all, I'm just my comment on that. I'm quite surprised that that respondents would use propofol for induction. That's quite interesting why they used, and the most common dose was 1 milligram per kilogram. The second is that almost 1/5 they have not used neuromuscular blocking agent, which is, I mean, kind of surprising to me as well. Do you have any ideas why it was like that?
Okay, so this result was why I was doing this presentation, because it's really interesting. But I don't know why doctors choose those drugs. Ketamine is the most beneficial in the hemodynamically unstable patients because it's released endogenous catecholamines, which can help these patients. And about the topic of neuromuscular blockade, there was 1/5 doctors who didn't use it because it was only 16%, but it is recommended to use these drugs, so I don't know why some doctors.
Okay, how about respondents that didn't use neuromuscular blocking agents and their level of expertise? I mean, how many of these who didn't use neuromuscular blocking agents were residents, so doctors without specialty, without full specialty training, and how many of them were specialists?
Yeah, I don't remember exact numbers at this moment, but when I analyzed the result, there wasn't that one part of these doctors, resident or specialists, where most of it didn't use. It was likely similar regarding all persons of responses to these questions.
Okay. It's a nice survey. The topic is quite interesting, and the results are a little bit surprising, but that's why they're interesting. Thank you. Thank you.
So congrats also on staying cool-headed during technical difficulties, because we know how it can bother the presenter. And I have a maybe kind of a trick question for you. Keto-rock or rocket? So ketamine first, rocuronium later, or rocuronium first, ketamine later?
That's really hard questions, and I think I will not be able to answer.
Okay, I have two questions. The first question is about your study group. As far as your study group is concerned, my question is about inclusion criteria. Did you include those patients in the operating theater only, or also those in intensive care units?
It was the survey, and the survey just said that the patient is in hemodynamic shock, and
so you have no distinction between the patients requiring anesthesia and intensive care treatment. Am I right?
Yes, there was no difference in this.
Okay, and the second question is, did you ask your participants about the rate of success was intubation achieved during the first attempt using those drugs preferred in your study, or you don't know the successful rates?
Unfortunately, that wasn't the question, so we don't have the information.
Okay.
I have a question also about the group of doctors who you ask them. This is in hospital or out of hospital? This is emergency situation out of hospital, because this is very important in the factor of which influence on which drug we use. Because I can imagine that in hospital it's preferred with propofol instead of ketamine.
The questions was made that I don't remember what at this moment that you have come to the patient who is in the hypodermic shock. So I think that it suggests that it is in the hospital situation.
But you are not sure.
The question was like I say, so it was not specifically said.
And also the last question from me, what was your contribution?
So our contribution was to make the survey and then analyze the all results, make the presentation, and present it.
Thank you very much for your presentation. And let's move on to the next presentation for today. Impact of a new utilization improvement program on platelet concentrate transfusion, a pre-post study presented by Michał Porada.
Good morning, everyone. My name is Michał Porada, and together with my colleague Jakub Murski, we are honored to present the result of our study titled Impact of New Utilization Improvements Program on Platelet Concentrate Transfusion, a proposed study. The study was carried out on the Department of Anesthesiology and Intensive Care at the Medical University of Silesia, under guidelines Dr. Piotr Czempik. Each year, millions of platelet concentrate transfusions are performed around the world. Despite being so common, the decision to transfuse is still often involves tricky decision-making. A physician might ask, does my patient really need a platelet concentrate transfusion? Is there active bleeding? Are there any other risk factors? And if the platelet count is low, how low is too low? That's why clear decision-making support can be so valuable. Implementing a standardized utilization improvement procedure might reduce this uncertainty and lead to better and more appropriate transfusion practices. So what did we want to find out? The study aims to analyze the impact of a new hospital utilization improvement procedure on platelet concentrate transfusions. This was a retrospective study conducted at the University Clinical Center in Katowice. We looked at adult patients who received platelet concentrate transfusions in 12 months after and 12 months before the procedure was introduced. The new procedure was based on the 2015 guidelines of the Association for the Advancement of Blood and Biotherapies. It includes clearly defined indications telling the difference between prophylactic and therapeutic transfusions. We then assess the appropriateness of each transfusion according to these criteria. There were 168 patients who received PC transfusions, 83 in first and 85 in second study period of our study. In total, there were 452 transfusions performed. 52.4% of the patients were male, and the median age was 67. As you can see, the transfusion count didn't differ between both study periods. In first study period, there were nearly 49,000 hospitalized patients and 83 PC transfusions and 225 PC transfusions, resulting in transfusion rate equal to 0.17 and transfusion incidence equal to 14.5. In second study period, there were nearly 49 hospital patients and 85 PC recipients and 227 PC transfusion, resulting in transfusion rate equal to 0.18 and transfusion incidence in 16.4. So now the characteristic transfusion before and after the introduction of the platelet concentrate utilization improvement program. Overall increase in PC transfusion appropriateness rose from nearly 49 to 60%. The biggest change was observed in scenarios therapeutic from 60 to 70%. All changes in transfusion appropriateness was statistically significant with p-value below 0.05. Now let's discuss in some more details. Here you can see all the scenarios, both therapeutic and prophylactic. Mild and severe bleeding were classified based on the WHO bleeding scale. We observed the biggest increase in patients with intracranial bleeding appropriateness from nearly 60 to 92% and immune thrombocytopenia from 0 to 100%. But we must be aware of the fact that the huge difference was caused by a relatively small group of patients with these diseases. To sum up, a simple strategy of introducing a hospital utilization improvement program adjusted to the local hospital population, backed by learning educational activities, modifying of computerized physician order entry, may lead to shift from prophylactic to therapeutic uses and overall increase in percentage of appropriate PC transfusion in patients with thrombocytopenia. Thank you for your attention, and we would be happy to take any questions.
Very much for your presentation. And what was your contribution?
My contribution was to prepare the presentation and present them.
Ja mam też konkretnego pytania, jeden komentarz, tylko że fajnie byłoby poznać, czy ten wzrost odsetek przełożył się na wyniki leczenia tych pacjentów, czy to śmiertelność, czy nawet wyniki jakieś drugorzędowe, mniejsze krwawienie i tak dalej. Rozumiem, że nie analizowali Państwo tego w tej konkretnej akurat pracy.
Thank you for this question. Yeah, we analyzed this data, but we didn't include it in this presentation.
I would be happy to ask some questions to you, Michał. First of all, did you assess platelet function in any of patients receiving transfusion? So in how many patients platelet function was the trigger for transfusion?
I thank you for this question. I don't remember particular numbers, but it isn't a very small group. I am not able to say what about number.
Okay, so maybe it would be easier for you to answer the second question. How many patients received any concomitant blood products? So in how many patients platelet transfusion was the only transfusion, and how many patients requires more transfusion of blood products due to massive bleeding, for instance?
It was assessed and included in our table, I think the second figure, but I didn't remember the particular.
So please check it on your presentation.
Okay. Yeah.
I can see it to answer my question by now.
Which one? The number of
now. As you can see, the number of transfusion with severe bleeding was 6, and after the implementation of the program, and 12 after the procedure was introduced.
So how many patients received any concomitant blood products? All patients with severe bleeding or not, any of patients with mild bleeding, because as I see, the majority of patients had mild bleeding, in fact.
I couldn't answer your question.
Okay, and my last question is about complications of transfusion, because an improvement in the program could be monitored also as well using some indexes related to complications of transfusion. It's the major contraindication to transfuse more than less. Did you notice any complications, and what type of complications were observed?
Thank you for this question. We can assess and observe three the most common complication. First of all, there is a fibrilline in non-hemolytic transfusion reaction, which causes mild fever and chills, and it's the most common. The second is TACO, which means a transfusion-associated circulatory overload. It happened when too much volume is transfused too quickly, and the frequency of the TACO is about one of transfusion of 200 transfusions, and the first, the most severe, is trially, which means transfusion related acute lung injury, which could be fatal, but it's rare. It's rare, and it's one of 2,000 transfusions.
Sure. But how many of them were observed in your study group?
We didn't assess the complication of.
Okay, thank you.
Thank you.
What is the reason? Why do you think that the number of transfusion doesn't change during the first compared to second year? What was the problem for us for thinking, and why people decided to transfuse the platelets? And what is the weak point?
I think the weak point is more that doctors more frequently checking and take the guidelines, and there is more standardized, not only the doctor's decision, but the doctors always, after the implementation of the program, they use the guidelines and didn't assess themselves.
Okay.
So, if you were to pitch the implementation of the new hospital protocol to clinical intensive care physicians in your own words, how would you like to convince them to stick to the protocol, that it's worth it? Because it is, but how would you describe it?
Yes, thank you for this question. It's hard, but we added reminders on the CPEO, and the physician, when they order the platelet concentrate transfusion, they see reminders to check the bleeding risk and to check one more time platelet counts.
Thank you.
Thank you.
Thank you again for your presentation. And let's move to the next one, the lactate to albumin. The pointer. And let's move to the next presentation for today, the lactate to albumin ratio and CRP to albumin ratio as predictive elements in critically ill patients, therapeutic plasma exchange in the intensive care unit. A single center experience presented by Krzysztof Jarczyński.
Good morning, my name is Krzysztof Jarczyński, and I would like to share with you results of our study about LAR and CAR ratio as a predictive element in critically ill patients. LAR stands for lactate to albumin ratio, and CAR stands for C-reactive protein to albumin ratio. We choose these indicators because they are cheap, fast, and available in their daily practice, especially in ICU. Literature suggests that they might have prediction power of mortality, and indicators based on parameter ratio are known in medicine for now. For example, neutrophil to lymphocyte ratio, which is now explored, for example, in the United States or in India. We aim to, first of all, evaluate the predictive value of LAR and CAR in ICU patients. Secondly, determine the cutoffs above which the risk of death increases significantly, and to check the predictive independence of the cause of admission. We collected the data retrospectively from AMS system, and we collected data from 144 ICU patients from Śląskie Centrum Chorób Serca in Zabrze. We compared results for survival and non-survival group, and we took our analysis first available measurement. We divided our population into 6 groups: circulatory failure, respiratory failure, vascular pathologies, septic shock, and sudden cardiac arrest and its consequences. If we couldn't fit a patient into one exact group, we fit him into a mixed group. So first of all, our patient's age was between 20 to 93 years. Mortality was at the level of 48.6%, and interqual values for deaf patients across LAR and CAR variants were higher. On the right side, you can observe the values for deaf group, and on the left side is values for the survived group. You can clearly see these values are lower than for the deaf group. These charts illustrate values of LAR and CAR for survived versus deaf group. We can clearly see that deaf group values are higher. Median values for deaf group for LAR values were 94% higher, and for CAR group it was 51% higher for deaf group. These differences are statistically significant, which is approved by Mann-Whitney's test. Spearman's correlation showed that LAR is moderately positive correlated with mortality, and CAR as well is positive correlated, but this indicator is weaker but still significant. LAR's area under the curve suggests that LAR is a strong predictor. Value was pretty good, and for values above 0.106 for LAR, mortality was on the level of above 76%, which were correlated with death risk increased at this point more than 5 times, and for values for CAR above 3.18%, mortality was 65%, and the death risk increased more than 3 times. Logistic regression described LAR as a very strong predictor. The similar situation is for CAR, but these results are not that spectacular. To compare it to the age was described as an insignificant predictor of death. these results are approved by p-value and 95% of PIs. And we can see that PIs include 1 and p-value is above 0.05. Mortality between our groups were insignificant, and as you can see on these charts, values for LAR and CAR across different groups were quite similar. Dividing our patients again into groups, LAR values in every case was higher for patients included into dev group in every case on this slide. Similar situation was for CAR value, but mixed group presented different scenario, but this group included only 7 patients, which group is definitely not representative. To conclude, LAR and CAR from the day of admission can definitely predict death in ICU patients, especially LAR. LAR values above 0.106 is a practical cutoff, which is correlated with increase of mortality above 5 times. LAR is a stronger predictor than CAR, which were approved by almost every statistics. And LAR is an indicator that need to be more widely studied. New publications should focus on the bigger population and to try to make better cutoffs with bigger accuracy. Thank you very much for your attention. If there's any questions, I'd be happy to answer them and invite you to the discussion.
Thank you very much. And what was your contribution?
The idea was suggested by our mentor, and from this point, I participated in almost every part of the study, excluding statistics. So I collected the data, extracted the data, and analyzed the results of statistics. I made the presentation with a script for this presentation.
Are there any questions from the jury?
Thank you for your study. Presenting the results of your studies. It's interesting. My question is because there are many factors that may affect mortality. In fact, yes, you pick up the 2 ratios that you chose to analyze. And I saw in one of the tables that as one of the confounders, you put age. Did you consider any other confounder that could affect your results, that could have affected the mortality?
Do you mean
in
some examples?
Multivariate analysis, basically.
We wanted to compare our results to any aspect. The first was the age. If we see that age is not correlated with mortality by itself, and we see that LAR and CAR value is, so we have approved that LAR and CAR prediction values is approved. You saw that the mortality was almost 50%, so not every patient on this ICU died, and age didn't decide about the mortality, but our predictors did.
So you considered age only? You considered sex or scoring on severity classification systems? Because we use a lot of them in ICU. Maybe one of them is Apache 2, SAP3. So far, there are a few of them that might be considered as confounders. Yeah. So if the patient is sicker in Apache 2, this might have affected mortality.
Yeah, we considered this.
It might be included in this multivariate analysis. Yeah.
Yeah, we considered that scales you mentioned. But we focused mainly on statistics, and we wanted to find some predictors that is easy for doctors to calculate. You can see on the results of biochemical results of patients and try to calculate and see if cutoffs are above or below, and if the larger study can predict cutoffs with bigger accuracy into clinical practice, it would be easier to try to define if a patient is more likely to that on ICU. Thank you.
Congrats on your presentation. So you analyzed the ratios from the day of admission, right? From
Yes,
the
first
day
measurement.
as first measurement.
Yes.
And then you repeated the measurements in some other days later during patients' courses?
We have a few ideas how to analyze the data. For this presentation, we took only first measurement, but we have idea to compare first measurement to highest measurement and to analyze the longest hospitalization by itself to have some picture how during hospitalization these ratios are.
So if we are treating the patient and analyzing those ratios, should it influence our next decisions in those first hours from admission?
That's a great question because this easy calculation can show that that patient is more likely to die, and we definitely should above this cutoffs undervise this patient more. But it is hard to define how should we undervise patient more on ICU patients. So we started with ICU patients to show doctors there can be easy value to calculate, but we want to try push it into internal medicine or cardiology in the future, because on this unit there's not this level of undervision for the patients. And I would like to highlight that our patients were cardiosurgeon and cardiologist patients as well in most cases.
Thank you.
Thank you very much.
Thank you very much for all your questions and for the discussion.
Thank you. And let's move on to our next presenter, Jan Osicki, Therapeutic Plasma Exchange in Intensive Care Unit, a single center experience. The floor is yours.
Good morning, everyone, dear jury. My name is Jan Osicki, and I'm honored to present you our study titled Therapeutic Plasma Exchange in the Intensive Care Unit, a single center experience under the supervision of Piotr Czempik, MD, PhD. Firstly, a few words of introduction. Therapeutic plasma exchange, commonly referred to as plasmapheresis, is a medical procedure that involves the removal and replacement of patient's plasma to eliminate pathogenic substances or replenish crucial ones in some disease entities, like for example, MNTS13 in TTP. The most current guidelines for therapeutic apheresis were released by the American Society for Apheresis, ASPA, in 2023. It is the 9th edition of these guidelines, and those guidelines categorizes disease entities into 4 categories and 6 grades. And the first category means that the TP is recommended as a first-line treatment, either standalone or in conjunction with other therapies. Second category means that TP is recommended as a second-line treatment. Third category means that the role of TP is not fully established and supported by evidence-based medicine, but it is worth considering with more tailored approach. And the fourth category is for diseases when TP is proved to be ineffective or harmful for the patient. TP is generally considered safe, but it carries potential risk, including hypotension, allergic reactions, infections, and bleeding complications. Each TP session aims to replace 1 to 1.5 of the patient plasma volume, and the duration is between 2 to 4 hours. The presence of comorbid conditions may influence the TPE safety profile. So monitoring specific laboratory parameters is crucial during TPE, to assess the patient's response and to detect potential complications. The aim of our study was to analyze TPE procedures in the intensive care unit of an academic medical center in Poland. And to achieve this, we collected indications that our patients had for the TPE. We classified them according to the ASFA guidelines, and we identified complications that happened. This was a retrospective case control study conducted in a department of anesthesiology and intensive care of Medical University of Silesia in Katowice. The studied period was from January 2019 to December 2024. And we retrieved clinical data from the electronic and traditional medical records. And every patient included in our study underwent therapeutic plasma exchange procedure. We collected various data like ICU and hospital length of stay, TPE indication, demographics, comorbidities, mechanical ventilation status, number of procedures per patient, type of replacement fluid, type of anticoagulant used, and complications. The median age of our patient was 52 years old. We had 27 women and 15 men. The median number of TPE per patient was 5, with the median ICU length of stay of 10 days. So that means that the patients received the procedure every second day on the average. These are the disease entities that we recorded. The most common is Guillain-Barré syndrome with the count of 13, and myasthenia gravis with the count of 10. And the third one is stiff person syndrome with the count of 6, which is quite interesting because this disease has prevalence of about 1 to 2 cases per 1 billion worldwide. And two first diseases have the grade of 1A and 1B. So the use of TPE is backed by evidence medicine with randomized control trials, and the strength of this evidence is very high. And the stiff person syndrome is category 3 and grade 2C, where the recommendations for TPE are weaker. But in the last edition of ASFA guidelines, it was specified that despite the low grade of the recommendation, up to 60 and over 60% of patients have some benefits from doing the TPE procedure. We had 31 patients that had ASFA category 1 diseases, 1 patient from 2nd category, and 11 patients from 3rd category. And we recorded 11 adverse effect complications. 7 were infections, catheter related. 4 were hypocalcemia, interestingly not in patients where the citrate was used as anticoagulant. And we had 3 hypotensions. And moving to conclusions, in a large majority of patients in the local ICU, TPE was performed as the established first-line treatment. Most patients were diagnosed with Guillain-Barré syndrome, myasthenia gravis, and stiff person syndrome. Only in a single patient, fresh frozen plasma was used as a replacement fluid. And due to the possible complications, TPE should be primarily used in ASFA category 1 and 2 indications. And thank you for your attention. I'm eager to answer any questions.
Thank you very much for your presentation. And what was your contribution?
My contribution was preparing the database, collecting the data, analyzing the data, preparing this presentation, and the script for it.
Are there any questions from the jury?
Okay, I will ask 2 questions. Both are related to the complications or side effects of the procedure. Was the number of infections related with the number of TPE sessions? And the second question is similar to this one because relates to hypotension. Was hypotension specific for any indication for TPE session?
So we did not do this correlation if the hypotension was specific to any kind of indication, but it was transient and quickly fixed. And could you repeat the first question?
The first question was about infections and the correlation between the number of TPE sessions and the number of infections, the risk of infection. And the second was about the hypotension. Was hypotension related to any specific indications for TPE?
So as our complication was mainly catheter related infections. So yes, the correlation might happen, but we did not investigate that if it was the case in our study. And we also did not investigate if the hypotension was correlated with any particular indication for TPE.
Was TPE successful in all the patients? How many procedures were required to achieve this success? Did you investigate it?
In most patients, 5 procedures were most patients underwent 5 procedures. We had only 1 patient, I think, where the number of procedures was 10.
Okay, thank you.
What about the death? How many patients died during because what the definition of successful is?
I don't have this data right now, but we collected it, and unfortunately, I don't have it right now.
Jedno pytanie, właściwie uwaga metodologiczna, bo w sumie merytorycznie rozmawiamy też o prowadzeniu badań naukowych i sposobach ich prowadzenia. Takie szybkie pytanie, bo wytyczne ASFA się zmieniały w trakcie tego okresu badania. 2019 i później nie pamiętam w którym roku, ale były nowsze. I czy ta analiza, którą prowadziliście teraz, była oparta w całości o jedne najnowsze wytyczne, czy te poprzednie okresy, 2019 rok, to była analiza wskazań na podstawie tych poprzednich?
No,
Może one się nie różniły w ogóle w tej kwestii, bo że nie pamiętam.
The differences were not so big, and we did our study according to the newest from the 2023. Thank you for all the questions.
Thank you very much. So let's move on to our next presenter, Julia Liepina, with the work titled Echoes of the Brain, Predictive Value of Optic Nerve and CRA or Ultrasound in Patients with Intracranial Hemorrhage Motility of RTB in
Good morning, ladies and gentlemen. My name is Julia Liepina, and today I have the pleasure with the ability to present you the effect of our work called Echoes of the Brain, Predictive Value of Optic Nerve and Central Retinal Artery Doppler Ultrasound in Intracranial Hemorrhage, prepared under the supervision of Piotr Czarpik, MD, PhD. In intensive care, we look for a clear signal that echo before our patient falls silent. Subarachnoid hemorrhage is devastating, and the mortality rates remain high, up to 65%, despite the advances in medicine. One of predictors we use is intracranial pressure, but the gold standard for monitoring intracranial pressure being EVD, external ventricular drainage, carries high risks for our patients, high risk of infections and other complications. So we decided to put our hands on a tool that can be found in every ICU, ultrasound. we decided to check if ocular ultrasound, quick, non-invasive, easy-to-perform method can reflect and can predict our patient outcomes based on ONSD reflecting the intracranial pressure and central retinal artery flow parameters measured by Doppler method that represent changes in cerebral perfusion. As per material and methods, this was prospective cohort study performed in a 10-bed academic ICU. Participants were 31 patients, 21 as a control group without brain pathology, 5 with intracranial hemorrhage being SAC, and 5 with non-subarachnoidal hemorrhage patients. We performed daily ocular ultrasound for first 7 days of stay. We measured the optic nerve sheath diameter, ONSD, and we measured flow parameters in central retinal artery. We also collected the data on prognostic scores such as Apache 2, SAPS, SOFA, GOSE, and data on ICU mortality. To analyze the data, we used statistical program with non-parametric tests, Spearman rank correlation, and logistic regression. What did we find in our study? We found no significant differences in ONSD between SAC, non-SAC, and control groups. The median ONSD remained in the range between 0.5 centimeter and 0.53 centimeter. ONSD to ETD, eyeball transverse diameter ratio, also showed no significant differences between groups. We found weak correlation of the right eye ONSD and ONSD ETD with SOFA score on the admission day, and no correlation with other prognostic scales. So they did not independently predict ICU mortality. As per central retinal artery flow, they also showed no significant differences between those groups of patients. In SAC patients, we found that higher peak systolic velocity, PSV, and mean flow through the artery initially was associated with ICU mortality. But after we adjusted it for confounders, such as age, patient sex, other prognostic scales, association lost significance. Combined model analysis revealed no statistical improvement of prediction. So what do we take from it? We all know that point-of-care ultrasound is a great tool. We should keep searching for the utility of it in the ICU to help our patients, to improve our predicting possibilities. But we need further, larger, standardized studies to see if ocular ultrasound can help us predict those outcomes, because our study showed that for now, these tools are insufficient. Thank you for your attention. Here are our references. And now I'll be pleased to answer any and all questions.
Thank you very much for your presentation. And let me ask you, what was your contribution?
Of course, thank you. Our contribution was performing the ultrasound after a period of preparation where we trained under doctors. Me and my research group, we performed the ocular ultrasound daily on a fixed hours. We appeared in the ICU and measured our patients. We also helped under our tutor guidance to prepare the study design. We analyzed statistics as a team, and then we prepared the abstract, the manuscript, and I prepared this presentation for you.
Ja zacznę może. Nie mam gotowi przed mówić po angielsku, także gratuluję. Natomiast co do przełożenia na wyniki końcowe, właściwie braku przełożenia na wyniki końcowe, to też jest tak, że ci pacjenci z SAChem giną, dlatego że rozwija się najczęściej spazm i niedokrwienie. I to się dzieje w późniejszych dobach często niż te początkowe, różnie. Z tego co pamiętam, to mieliśmy przypadki nawet po 10-14 dniach i może to jest jakieś ograniczenie, dlaczego nie udało się tego związku wykazać na początku. Druga rzecz, która mnie zawsze ciekawiła i to chyba ma znaczenie, tak mi się wydaje, czy ci pacjenci do pomiarów są w miarę wystandaryzowani pod względem pewnych rzeczy. Po pierwsze tego, że wykonuje ten pomiar za każdym razem jedna i ta sama osoba. Druga kwestia to taka, czy ci pacjenci się różnią na przykład pod względem parametrów wentylacji, takich jak PIP, który może wpływać jednak na wzrost ciśnienia wewnątrzczaszkowego przy jakichś wyższych wartościach, nie mówimy o takich fizjologicznych 5 czy tam 7. I druga kwestia, pozycja głowy. Nie? Czy był jakiś standard? Czy ci pacjenci byli w tych samych pozycjach? Czy te PIP-y może analizowaliście gdzieś przy okazji? Bo rozumiem, że wszystkiego nie da się pokazać w ciągu 7 minut, ale może macie takie dane gdzieś obok.
Okay, so I will start from the end. The head position and our patient position was standardized. Patient laid flat on their bed, and we always try to put the ultrasound probe in the same way. As per the person performing the test, it wasn't standardized. Our group consisted of 5 people, and on different days, different people measured it. However, we think that our abilities to perform this ultrasound were on very similar levels, and that's what was kind of one of the points of trying to do it that way, because we tried to find something easily accessible for all the doctors, and the doctors aren't standardized. Our abilities, they range from very low to very high, so that was one of the points of seeing if we will find something in kind of natural setting, I could say. And what was the beginning? Oh, the parameters. Patients weren't standardized. We didn't collect the data and we didn't check it. However, that also showed us kind of if it can be used clinically, because patients with SAC, with other intracranial bleeding, they differ a lot between particular patients. So maybe I can say non-standardized form of the study showed us how the real clinical utility of this test can look if it will be applied wider. Any other questions? Okay, thank you very much.
Thank you very much for an amazing presentation. And now let's move on to our next presenter, Liliana Bantek, with the work titled Utility of LTV in Predicting AKE Following CABG. The floor is yours.
Morning, everyone. Actually, my name is Ewa Klińska, and Liliana Obajtek is on the audience. We represent Medical University of Silesia. It's a pleasure to be here and to present the topic utility of RTW in predicting acute kidney injury following CABG. Acute kidney injury is a serious clinical condition that affects around 13 to 20% of patients. It is often diagnosed late, which worsens prognosis. Early detection could be life-saving. Now, this was the main aim of our study, to identify RTW as the valuable parameter in this case. At the beginning, I would like to briefly outline the definition and explain the terms. RTW is the parameter that reflects variation in the size and volume of red blood cells. The normal range is between 11.5% and 14.5%. AKI is acute kidney injury, sudden reduction of kidney function. Kidney disease improving global outcomes in 2012 published criteria of defining acute kidney injury. Patients must have one of the following: an increased creatinine of 0.3 milligrams per deciliter or more within 48 hours, or increased in creatinine by 1.5 times baseline on more than occur within 7 days. Or urine volume that is less than 0.5 milliliters per kilograms per 1 hour or 6 hours. Our study utilized only these first two criteria. The third one was not applied to the lack of available data. Finally, CABG is coronary artery bypass grafting, which is a surgical procedure used to treat coronary heart disease by improving blood flow to the heart. Our prospective analysis was conducted at the Silesia Center of Heart Disease in Zabrze. The study included 182 patients who underwent coronary artery bypass grafting and were admitted to the intensive care unit in 2023. Clinical and laboratory data were collected from the AMMS system. We excluded patients based on these two following criteria. The patients who received blood transfusions on the day the postoperative complete blood count was collected, 88 patients, undergoing off-bone coronary bypass. As you can see on the graph, acute kidney injury occurred in 12 out of 182 patients, which amounts to 6.6%. It has been observed that the majority of patients undergoing CABG are male, a median age of 68 years, and age range of 43 to 85 years. The most common diagnosis was arteriosclerotic heart disease, observed in 119 patients. The next one, most frequent diagnosis were unstable myocardial infarction in 25 patients and unstable angina pectoris in 21 patients. There was no significant difference between patients who developed acute kidney injury and those who did not. In our analysis, we observed that patients with acute kidney injury significantly higher postoperative RDW values compared to those without. However, preoperative RDW-CFL values did not differ significantly between the two groups. Renal function markers differ significantly between the two groups. Both preoperative and postoperative SCR levels were higher in the group with acute kidney injury. Also, preoperative and postoperative GFR values were lower in patients with acute kidney injury, with a significantly higher reduction in GFR observed postoperatively. The mean difference between preoperative and postoperative delta RBC was significantly greater than in non-acute kidney injury group. A similar pattern was observed for the difference in hemoglobin levels and delta HB. A univariate logistic regression analysis showed that factors such as postoperative RDW-CFL, pre and postoperative SCR, delta GFR, delta RBC, and delta HB were associated with an increased risk of developing acute kidney injury. However, statistically significant correlations were observed for postoperative RDW-CFL, delta RBC, and delta HB, with the strongest predictive power found for postoperative RDW-CFL and delta HB. The area under the curve for postoperative RDW was 0.674. A cutoff value was determined to be 14.4 with sensitivity of 58% and specificity of 91%. For preoperative RDW values, the area under the curve was 0.624, indicating a small and discriminative ability in predicting acute kidney injury. The optimal cutoff point for preoperative RDW was 14.0 with sensitivity of 42% and specificity of 92%. we came to the conclusion that preoperative RTW may hold small potential prognostic value. In conclusion, although elevated preoperative RTW-CV reflect a higher risk of acute kidney injury development based on our results, it cannot currently be recommended as a standalone prognostic tool in this patient population. Further large-scale prospective studies are necessary to better define the role of RTW. Preventive strategies for acute kidney injury in the intensive care unit in Silesia Center of Heart Disease are well established, as evidenced by a relatively low incidence rate of only 6.6%, which deviates from previously reported averages. Thank you for your attention. I would like to kindly welcome on stage my colleague Juliana Obajtek and also a co-author.
Thank you very much for your presentation. Let me ask you, what was your contribution?
All our group collected data from the system. We made a huge database. Liliana was main one who contributed to main for the database. I did the logistic regression and the part of presentation and speech with Juliana.
I am gladly here to support my friend in the discussion and also to answer your question better. It would be easier for us to answer it both.
Are there any questions?
Thank you for your presentation. And one of the exclusions was blood transfusion on the day of surgery. Is that, am I right?
Yes.
Only on the day of surgery?
Only on the day of surgery.
Okay, how about?
On the day when we collected the morphology. Yes. Because we collected the morphology, the post-operative morphology, we collected the first that was after the surgery.
Yeah,
and
so
then
on the day of surgery.
Yes, and
it was on the day of surgery because morphology,
yes.
Yeah, CBC would be, I presume, well, I'm pretty much sure that it was performed the moment the patient returned from OR, yeah?
Yes.
How about preoperative transfusions?
There was no preoperative transfusions in our patients. There was no preoperative, so there was no exclude.
Okay. So none of the patients received blood transfusion in the previous 3 months?
We didn't have the data to collect that, and we didn't have the...
But as far as hospital stay is concerned, there was no preoperative transfusion at all?
Preoperative, we don't really know. We know only with the day they admitted to the hospital.
Yeah, so, but in the hospital, they were not receiving transfusion before surgery?
No.
In Silesia Center?
No.
Okay. Okay, thank you.
Okay.
Just please remind me, because in fact the AKI incidence was quite low. It was like 6.6%. And as far as cabbage procedure is concerned, I remember larger numbers, larger percentages. So what's the average incidence rate of AKI following cabbage, according to the literature?
Around 20 to 30%.
Yeah. So what are the preventive measures that are used in Silesia Center to get this result?
So difficult actually for our students.
Yes, but I'm just wondering, what's the magic there? Anesthesiologists. Yeah, that's, I can understand.
Not surgery.
You have a comment, Dr. Czynowska? Please.
I don't really know. But we are happy that it's only 6.6% because the study was strict connected to the ACI. So I think this right numbers. What can I say? What can I say? And interesting, but for me, the interesting was the number for people with ACI, hemoglobin HB, hemoglobin level was higher compared to no ACI. This is also in the opposite because the low number, the low hemoglobin is connected to the worst outcome. So the further further data, further study was needed to confirm this data.
Can I
But
ask
thank you very
a
much.
question? I'm not sure if you are able to answer. You collected lots of CBC parameters. Could you, because I might just miss this information, what was the hemoglobin before surgery?
Before surgery, we have 3.4.
Hemoglobin before surgery.
No, I don't remember exactly.
On our presentation, it only showed the delta of hemoglobin. We have the preoperative hemoglobin rates, but we don't have it right now. We don't remember the numbers.
Okay, thank you.
Would you like to show us or not?
Sorry to interrupt for your discussion, and thank you, Eva, for your response. However, I need to add that I was really surprised by this low level of acute kidney injury after surgery, and I asked twice to verify this low level. However, in fact, it is so low. Maybe it's the impact of preoperative preparation of the patients in prehabilitation center, in prehabilitation ambulatory center, and this is why it decreased really in recent years. Sorry for interruption, but I needed to add that.
Thank you very much. Thank you very much again for an amazing presentation. Let's move on to our next presentation for today, which is the evaluation of the accuracy of selected formulas for estimating body weight of children in emergency situations by Magdalena Kwiatkowska.
Good morning, everyone. My name is Magdalena Kwiatkowska, and I have the pleasure of presenting the findings of our study, evaluation of the accuracy of selected formulas for estimating body weights of children in emergency situations. Accurate weight estimation is essential for calculating drug dosages and selecting medical equipment or setting defibrillation energy. However, quickly weighing children in such circumstances is often challenging. In clinical practice, pediatric weight is typically estimated using either age-based formulas and length-based tools like the Brussels tape and paper tape. While age-based formulas require no additional equipment and are easy to apply, they tend to be less accurate than length-based tools. Length-based methods are generally more precise because they take body habitus into account, but they require additional equipment and depend on having the tape available or trained personnel, which can be difficult in time-critical situations. The aim of our work was to assess the accuracy of various pediatric weight estimation formulas by comparing them to actual measured body weights of hospitalized children. To achieve this, we conducted a large retrospective analysis
of 12,103 children aged between 1 to 10 years, all admitted to Silesia Center for Heart Diseases in Zabrze between 2014 to 2024. Each child's weight was measured upon admission using calibrated medical scales. Exclusion criteria was incomplete or missing data and duplicate admissions. We calculated estimated body weight using the following 8-base formulas: original and updated versions of the IPOS formula, Ruscombin Owens, Randall rule, the best guess, and the sham formula. Then we compared estimated weights to actual weights using black analysis, comparing estimated and comparing the mean difference between measured and actual weights. What did we find? The median age of our study population was 5 years, and the median body weight was 18 kilograms. As you can see, the updated IPOS formula proved to be the most accurate in children aged 1 to 5 years. The black admiral plot indicated that this formula underestimated actual body weight by an average of 4%. The upper limit of agreement, the 95% confidence, was 31%, where the lower limit was minus 38%, resulting in a total range of about 70% between the limits of agreement. On the other hand, the best guess formula indicated the lowest accuracy among children 1 to 4 years. The blunt animal plot indicated that this formula underestimated actual body weight by an average of 42%. The upper limit of agreement 95% confidence was 27%, while the lower limit was minus 111%, resulting in a total range of 138% between the limits of agreement. In conclusions, where pediatric patients' body weight is unknown, the updated IPOS formula is currently the most reliable formula for estimation. Other formulas carry significantly high risk of error and should be used with caution. Therefore, there's urgent need to develop more accurate, up-to-date methods to improve the quality of pre-hospital care. Thank you for your attention. I look forward to any questions you may have.
Thank you very much. And let me ask you, what was your contribution?
My contribution included collecting data, preparing this presentation, and analyzing the data.
Okay, any questions?
So, what is the highest error that we can safely commit in order not to harm our patient from the underestimation or overestimation point of view?
It's quite difficult question. I can give you now a definitive answer.
As we've seen, some of those scores have very high percentage of potential error, right? So by using them, and in daily practice they are used frequently, we now saw how much, how big of a mistake can we make.
Of course, I think that we must take into account any other clinical features when we take care about patients in hospital care.
Thank you for your work, for your results, presenting your results. And my question is because you showed that there were over 12,000 patient data. Could you tell me how did you possibly could easily retrieve this data from the hospital information system?
Of course, our team collected only part of this data, so from the arms only.
But did you do it like manually, or was there support from IT team that retrieved this data for you? I mean, how can you? I mean, retrieve. You have to go into 12,000 patients in profiles. I would call it profiles. Yeah, yeah. You go into the patient. You search for this data. How could you do that with 12,000 patients?
We gave
like
support.
manually?
We gave a support from IT team.
Okay. So the IT team provided you with the data, or did you done some of this collection yourself?
Then we collected part of this.
Part of this you collected, and
yes.
part of this was provided by IT team. Okay. I'm surprised that so many formulas are available. I wasn't aware of it for weight of the pediatric patients. Is this updated Apple's formula recommended one in modern times? I mean nowadays, is this the formula that we should use, or are there any alternative formulas that are recommended that we should use?
I think this formula is currently the most reliable, and the study that we review says that this formula should be chosen.
And it is recommended by guidelines.
Yes.
Okay. Thank you. No further questions.
Okay, and I have the last question, I think. When you see the charts for the child growth and the body mass of children, you see that this is quite inconsistent in subsequent years. Especially the growth accelerates in first 12 or 24 months. There is a correlation between age and growth in the second several years. So my question is, did you try to verify if those formulas gave similar differences in subsequent age groups? Because as you presented at the beginning, the formulas differs usually between age groups, especially newborns. However, there are some deviations. Some of the formulas are devoted to children aged 1 to 9, and some 1 to 12, and 1 to 14. I wonder if you verified if the difference between actual and estimated body weight is the same in some different age groups.
Fortunately, we didn't carry this analysis, but I think it's
I think it would be obvious to verify it because your work is very practical. It's very important from practical point of view. And maybe that's the point, that the difference, the error relates maybe to the age of children, of Polish children, because the flow charts are different in different populations. So maybe Polish population is different to those Europeans that were used to create those formulas before. So please check it later.
Okay. Thank you very much.
Chcielibyście dodać komentarz?
Chodzi o mikrofon.
No, gratuluję tej pracy, ponieważ wydaje mi się, że ta rzeczywiście zwrócona przez Pana ta uwaga na tą olbrzymią grupę pacjentów. Czasami jest bardzo trudno zebrać taką grupę chorych. I to rzeczywiście, jeżeli nam się uda dostosować formularz do określonego wieku, będzie naprawdę super praktyczną informacją dla lekarzy, którzy decydują o tym, bo o ile dorośli, to my kalkulujemy tam mniej więcej, czyli te 75 kilo, natomiast u dzieci to ma absolutnie istotne znaczenie co do dawkowania leków, a później spodziewanego efektu. Także to mój komentarz, że gratuluję pracy i naprawdę to będzie bardzo fajna przyszłość. No, chciałabym zachęcić do dalszej pracy nad tym, bo rzeczywiście uwaga profesora jest słuszna, że musimy po prostu znaleźli taką, w zależności od wieku, od grupy wieku, właściwą formułę, albo dostosowali ją do tego i czy to ma przełożenie później na dawkowanie, więc no, gratuluję pracy.
Thank you very much again for an amazing presentation. And let me ask you, is there with us Artur Ross or Dominik Dęczyński, Michał Kostro? No? Okay. So let's move on to the next presentation, which is the sinking under the surface. Impact of fluid intake and balance on cardiovascular and respiratory status in the ICU by Julia Lipina.
Pytanie było czekać na doktora Krupa, aż wróci, czy on wrócił?
I nic nie robił. Coś się wydarzyło, więc myślę, że...
Good morning again, ladies and gentlemen. My name is still Julia Lipina, and right now I have pleasure of presenting you our work called Sinking Under the Surface, Impact of Fluid Intake and Balance on Cardiovascular and Respiratory Status in the ICU, that was carried out in the Department of Acute Medicine of Faculty of Medical Sciences in Zabrze of Medical University of Silesia under the supervision of Professor Łukasz Krzych, MD, PhD. I would like you to imagine someone who is drowning. What you see is human in distress in a huge body of water. But sinking in the ICU happens the other way around. In a human body, there appears excess water slowly drowning our patient's organs. As we know, adequate fluid management is a key to good intensive care. Fluid imbalance, both insufficient fluid therapy or excessive fluid therapy, can affect pulmonary function, cardiovascular function, and general patient condition. Mechanically ventilated patients are especially vulnerable population. They're already in a huge distress, and inadequate fluid therapy can worsen their condition, as well as adequate fluid therapy can help them a lot. That highlights the need for adequate fluid management in this population. The aim of our study was to assess the correlation between daily fluid intake and fluid balance with selected hemodynamical and respiratory parameters in critically ill, mechanically ventilated patients. As a hemodynamical marker, we picked lactate, and as the respiratory parameters we analyzed, we took the PaO2 over FiO2 ratio. The study was carried out in the Silesian Center for Heart Disease in Zabrze, and it was a retrospective study encompassing patients admitted between January 1st and December 31st of year 2024. We collected 44 patients that met our criteria, and we took the complete medical records from the first 8 days of their ICU stay, including the day of admission as a day 0, so the first week of ICU stay. We collected clinical and demographical information such as fluid intake, fluid loss, fluid balance, lactate level, PaO2 over FiO2 ratio, and that gave us 260 correlation pairs we analyzed using Rank-Spearman test. Median age of our patient was 72 years old. In the group, we had 32 males and 12 females with different reasons, and we differed them due to reason of admission. 38 were admitted due to acute cardiological reason, and 6 of them due to acute non-cardiological reasons. The criteria they had to meet was that they had to be intubated during first 72 hours of admission. We also excluded incomplete records, patients who were transferred between different departments back and forth. When we analyzed the impact, we found statistically significant correlation between fluid balance and lactate level and fluid intake and lactate level, informing us that excessive fluid therapy can worsen our patient's perfusion, so worsen hemodynamical function. We also found non-statistically significant weak correlation between fluid metrics and respiratory parameters. What should we take from it? High fluid intake is linked to impaired tissue perfusion in patients, especially in patients under mechanical ventilation with acute cardiological conditions. So that tells us that we should optimize and individualize fluid strategies for each patient that we're treating. We also think that it might affect respiratory parameters, but that needs further, larger, better standardized, maybe prospective study. Thank you very much for your attention once again, and I'm pleased to answer any questions.
Thank you very much. What was your contribution?
We contributed in collecting the data from the ICU observation charts from the online medical records. When we collected the data after consulting our mentor, we prepared the study design and we found the aim of our study. We defined it. We also decided on which correlations we want to check. And as for me, I prepared the presentation and all of my team wrote the abstract that you were able to read.
Thank you. Are there any questions from the jury?
So I think you've touched upon an issue that's extremely important and discussed on practically every anesthesia conference, because hypovolemia and hypervolemia and Frank-Starling curves are something that bothers us from decades, I think. I'm curious if you've paid attention, because we tend to calculate daily fluid balance of our patients, and what's, from your point of view, is important in terms of correctly calculating like fluid intake and fluid excretion during the typical 24-hour period?
In our study, we've included all of the fluids given to our patients. So not only what we call fluid therapy, so the Optalite, Plasmalite, but also all of the drugs that were diluted in different fluids. We also included the blood concentrate, the platelets, all of the blood products transfused to our patient. If our patients were able to drink on their own, because some of our patients were extubated, for example, in the 4th day of study, and we still continued on including the records because at one point in time in our study, they were mechanically ventilated. So also the oral fluids, if they received intravenous feeding or other type of feeding. And when it comes to fluid loss, we also tried to not only for the urine passed by patient and from what the ultrafiltration if they were on CRRT, but also we tried to include feces if there were if they were counted and accounted for in the observation charts, we also included them so that we don't miss anything.
Thank you. So you did it very thoroughly. And just out of curiosity, did you have any standardized formula for calculating the respiratory fluid excretion?
No, sadly, because due to the retrospective nature of the study, these data weren't available to account for us. But we're thinking of conducting the prospective study that will examine this topic even more thoroughly.
Thank you. Because that's also something that sometimes may be a problem for us in our daily work. So yeah, thank you very much for your question.
Ja po polsku, nawiązując do Michała, to jest bardzo istotny temat. Rzeczywiście każdy lekarz, który stoi przy łóżku pacjenta, zastanawia się tak naprawdę, jak powinien wyglądać balans pacjenta, balans płynowy pacjenta. Tylko pytanie jest takie, Państwo brali 8 dni, prawda? Co znaczy dla Państwa dodatni bilans płynowy? Czy udało się wyznaczyć pewną wartość, powyżej których na przykład było to już było przelanie, czy też objętość płynu była zbyt duża? Tylko że napisaliśmy taką pracę też tej samej grupy pacjentów i bo 72 godziny była dla nas takim absolutnym czynnikiem, że jeżeli do 72 godzin byliśmy w stanie wyzerować ten bilans, czyli tak naprawdę uzyskać plus minus 300 co do codziennego bilansu, to ta wartość to nie wpływało to na śmiertelność. Czy Państwo zwrócili uwagę, jakie bilansy dodatnie wpływają na śmiertelność, a jakie moglibyśmy sobie pozwolić na nie, nazwijmy to? Rzecz dotyczy, wracając do dokładnej wartości. Czy jakieś Państwo kalkulowali dokładną wartość, jaką objętość płynów uznali za dużo?
No, not yet. We are to conduct further analysis because we've collected a lot of data. In this particular part of the study, we matched each day lactate and PaO2 with that day and that patient's fluid intake, fluid loss, and fluid balance. And we didn't put a threshold for like this patient was over therapied with fluid and this patient didn't get enough fluid. We only got strict values, like for example, +1 liter or -1 liter, indicating if the fluid balance was positive or negative, but we are yet to analyze the correlations you spoke about.
Ja mam jeszcze komentarz, pytanie w zasadzie, bo jest Pani lekarzem. Jak Pani myśli, gdzie my najwięcej przelewamy pacjentów? Bo mamy jakąś objętość płynów, którą pacjentowi podajemy. To są płyny resuscytacyjne, rozpuszczalniki dla leków, żywienia i tak dalej. Jak Pani myśli, gdzie jest ten punkt, gdzie powinniśmy zwrócić największą uwagę na objętości płynów, bo tych pacjentów przelewamy tymi płynami i to doskonale wiemy.
I'm not a practicing clinician yet, but I think, like in my mind, there appears the thing about the drugs that doctors might forget that the 250 milliliters paracetamol is also a fluid that can affect our patient and should be accounted for. So I think that the drugs might be a problem, and also not factoring in that some of ICU patients are conscious and they might be drinking, they might be, their family might be making them tea, for example, while visiting. So not taking into account also the fluids that our patients take in orally and the fluids from foods taken by patients who are able to eat on their own.
Tak, no zdecydowanie leki najbardziej, nie? Są takie leki, które mamy rozpuszczone i nie mamy za bardzo wpływu na to, w jakiej objętości je podamy, szczególnie mowa o antybiotykach, które często podawane są wielokrotnie w ciągu doby. Takim antybiotykiem jest inezolid, który ma objętość 500 ml. No i tyle, ale na całą resztę mamy wpływ, nie? Czyli niekoniecznie być może każdy kolejny lek musimy podawać w objętości 500 ml, kiedy można zastosować 20 ml i to jest fajna droga, żeby powalczyć z tym przewodnieniem. A druga kwestia jest taka, że przypomina mi się zawsze sytuacja, jak siedzieliśmy wieczorami jeszcze na dyżurach na studiach i liczyliśmy te bilansy i tak siedzieliśmy koło siebie, każdy miał jedną kartę z 10 i ile dasz temu pacjentowi, że odparował dzisiaj? A tam 500, a drugi da 300, nie? Przez to te drogi, kiedy neutralnego bilansu trudne do ustalenia, nie? Bo one sami między sobą przeróżnimy w granicach litra teraz. tych naszych rozmowach, bo tu pacjent zagorączkuje, ten za 1 stopień wyższej temperatury da pacjentowi plus 500, a inny plus 100. Trzeba pewien standard, wydaje mi się, przyjąć w oddziale, żeby te obliczenia miały sens. Ale to taka uwaga tylko do przyszłych badań ewentualnie w tym temacie, bo to mega ciekawy temat jest.
Okay, thank you very much for all the questions.
And let me move to our last presentation for today, which is the incidence and risk factors for post-operative nausea and vomiting after elective cesarean section. Presented by Olivera Vincenzo.
Dear committee, dear colleagues, my name is Olivera and I'm from Serbia. And today I'm going to talk about the incidence and risk factors for postoperative nausea and vomiting after elective cesarean section. Postoperative nausea and vomiting are the most common side effects of anesthesia, and they are usually overlooked. They are defined as nausea and or vomiting in the first 24 or 48 hours in the postoperative period. The aim of our study was to calculate the incidence of postoperative nausea and vomiting on the Clinic for Gynecology and Obstetrics in Novi Sad, also to determine if the APOL score may be used for obstetric patients, considering the fact that the APOL score excluded obstetric patients when it was made in the 90s, and to see if there is a difference in calculating the risk assessment between the opioid use in the first 12 hours and the 24 hours as per APOL score. Our study was done as a prospective cohort study, which included 51 obstetric patients that were hospitalized for an elective cesarean section. Patients were excluded if they were younger than 18 years old and if the cesarean section in the end was an elective. It was done on the Clinic for Gynecology and Obstetrics of the University Clinical Center of Vojvodina in Novi Sad. We had 47 participants under spinal anesthesia and only 4 participants under general anesthesia. And they were questioned by me with a self-made questionnaire that had 27 questions. For statistical analysis, we used the Shapiro-Walk test to evaluate if the values were non-parametric or parametric. And since the values all were non-parametric, we used the Spearman test for correlation. And the study was approved by the Ethics Committee of the University Clinical Center of Vojvodina. The incidence of postoperative nausea was 19.61%, while the incidence of postoperative nausea and vomiting was only 3.92%. Looking at the occurrence of postoperative nausea and vomiting, the most frequent occurrence was in the first 2 hours after the operation, where we had 5 patients with nausea and 1 patient who also had nausea and vomiting. We had 3 patients who had intraoperative nausea, which was after getting the anesthesia, but it subsided by itself. There was no need for any rescue medication. Also, we saw that 5 hours after the operation and 30 minutes after getting tramadol, there were 2 patients, of which one had nausea and vomiting. And we had 2 patients the next day who had experienced nausea, but all of those patients didn't receive any rescue medication because the nausea subsided by itself in less than an hour. And the vomiting, when it occurred only once. Looking at the correlation between the APFL score, original APFL score, where we considered the use of opioids in the first 24 hours, there was no correlation. But when we considered the first 12 hours of opioid use, we had a statistical correlation when the P was less than 0.05, and excluding the patients under general anesthesia, which didn't have any nausea and vomiting, we got even a better value, which was P was 0.01. Looking at the difference between the original APFL score and the modified APFL score, we didn't have any significant difference when we tested with the Wilcoxon's test for difference. But we think that's only because we have a small pool of patients, which we will consider in the future to expand the pool. And in conclusion, postoperative nausea and vomiting are the most common side effects. They may sound insignificant, but they can come with quite the complications. So it is really important to assess the risk, to use pre and post-operative prophylaxis, antiemetics, and to see if there is a way to avoid opioid use at least the first day, which we do by a multimodal approach with an NSAID. And while the APFL score is not 100% accurate, it can be used for risk assessments pre and post-operative if we consider the first 12 hours of opioid use. Thank you so much.
Thank you very much for amazing presentation and also for coming here from so far away from Serbia. And also let me ask you a question. What was your contribution?
Well, my contribution was almost everything except the aim, because my mentor gave me an aim. He told me what to do. And I really liked doing all of this by myself, but it was under his supervision. I mean, I've done everything and he controlled it. And I've also done the risk factors and statistical correlation and in univariate and binomial logistic regression. But because of the small pool of patients, we didn't have any significant correlation. And that's the reason why I didn't put this on the presentation.
Thank you very much. Are there any questions from our jury?
So also congrats on your presentation, because this issue is also very clinically significant. We want our parturients to be comfortable, right? So I'm curious, because you've said that you've evaluated elective C-sections. So was there any pre-operative prophylaxis given to the patients? And if yes, what kind?
Every patient on our clinic gets metoclopramide, like maybe an hour before the operation, and post-operation they get dexamethasone, and if they have a higher risk of developing or they have a history of already developing after a cesarean section, they also get ondansetron.
Okay, so I have a comment and a question for you. Let's start with the comments. As I remember, the issue of postoperative nausea and vomiting was the aim of the research of Dr. Michał Pluta. It was the first research that he conducted under my guidance, as I remember. And this is a very important issue. However, I am pretty sure that none of your conclusions is related to the aim of your study. As you see your conclusions, there are plenty of them, about 6 or 7 of them, and they are obvious. They are rather rational. Why to conduct, to carry on studies devoted to postoperative nausea and vomiting. So my general question is, what is your main conclusion? What is the conclusion of your study, in fact?
Well, when I done my study, when I done my research, there were some studies that didn't give any prophylactic, or they were only given rescue medications, and the incidence of PON was even 70%. And they were an Estonian study. But when I researched all of the other studies, the lower incidence I came across was 30%. And they
okay, thank you.
So I have a second comment, if I may there. Why tramadol? Because we know through the pharmacodynamics and pharmacokinetics that there are slow metabolizers and fast metabolizers of this particular opioid, and there is a known higher risk of potential nausea and vomiting. So maybe it's the issue that your country prefers this type of drug. However, are there any efforts made to change that, to maybe choose other types of opioids? Because there are opioids known for better effect in especially pregnant patient population.
I'm pretty sure that because I didn't see any other medication on the medical records. I'm pretty sure that they only had tramadol in the clinic. And when we were on other clinics, they also told us that the only opioid they don't have is tramadol. So I think that's just because of our country and our health system. But usually, tramadol is only given as a rescue medication if the pain is high, even after giving the NSAIDs. Almost every patient gets NSAIDs, and sometimes they even get tramadol after that. And the only reason why I don't know why some are getting tramadol and some are getting it as a rescue medication after the operation is because probably we have different anesthesiologists, and I couldn't ask them all why they are giving it. But I will think about that in the future because I want to expand this study. Thank you. Thank you for all the questions.
I have one question about do you check the level of the pain in this pregnant woman? For example, in the scale, because if you connect it to the medical which will release the pain, so we can have more information about if we should avoid the opioids or not. Yes, because in this study it's this lack of if they are happy without opioids or not. What is worse, to feel the pain or to feel the
yeah. Well, I don't have all of this information because I'm pretty sure the anesthesiologists do assess that because my mentor does. But the problem is I did not see any of that on the records, not on electric records, nor on the paper, which I really think it is really important, but I don't know any information about that.
Yes. But this is for future study.
Yes. Thank you. Thank you.
Thank you. Thank you very much. Ladies and gentlemen, all the submitted papers have been presented. We congratulate all of the presenting authors and participants of our session. And at this point, I'd like to ask Professor Łukasz Krzych for a few words to sum up our session.
Przepraszam, czuję się bardzo wywołany do tablicy. Przepraszam, że nie mogę być kolejny rok u was, ale zawsze coś mi wyskakuje w ostatniej chwili. Znamy się już wiele lat. Cieszy mnie to, że nie ustajecie w swojej pasji do tego, żeby zrobić coś więcej niż tylko uczyć się na studiach. Bardzo mi podoba się ta inicjatywa, która od was wychodzi, żeby rozwijać się naukowo. Są to dobre podwaliny do tego, żeby zrobić coś w kierunku opracowania swoich doktoratów, a może i więcej. To już, nie wiem, chyba jest 10 lat, kiedy ja uczestniczę w spotkaniach SIMkowych, jeszcze wtedy nie SIMkowych. I niezwykle mnie buduje, kiedy widzę w tej chwili już w jury osoby, które wyszły spod moich skrzydeł i z którymi ja opiekowałem się te kilkanaście lat temu, które w tej chwili stają się jurorami i mentorami. I życzę wam, młodzi ludzie, tego, abyście w następnych latach właśnie bazując na swojej ciężkiej pracy, znaleźli się w tym miejscu, w którym my jesteśmy, jako wasi starsi koledzy, jako osoby, które oceniają was. Czasem myślicie, że niesprawiedliwie, ale patrzą na to z troszeczkę innego fotela. bo daje to olbrzymią frajdę i motywację do dalszego działania, kiedy widzi się no tak naprawdę owoce swoich czynów. I tych owoców waszych czynów wam życzę nie tylko pod postacią nagród na konferencji, bo to jest nieistotne i tak jak w tej chwili wszyscy mówią o maturach, że to nie ona czyni człowieka, tak samo też nie nagrody konferencyjne, ale praca włożona i konsekwencja w tym, aby starać się być coraz to lepszym. Więc życzę Wam dobrej zabawy jutro wieczorem, chyba bardziej niż wygranych konferencyjnych, a tym, którzy zainteresowali się nauką, aby w tej nauce byli coraz to lepsi i lepsi i w pewnym momencie byli, tak jak ja, czy pani docent, czy pan docent, samodzielnymi pracownikami nauki, którzy będą mogli prowadzić Was dalej, a tej dwójce pozostałym osobom, czyli Agnieszce i Michałowi, życzę, żeby już wkrótce tymi samodzielnymi pracownikami nauki zostali i mogli być dalej mentorami, już nie tylko dla Was, studentów, ale również dla absolwentów. Bardzo się cieszę, że nasza sesja anestezjologiczna trwa i bardzo się cieszę, że pomimo wielu różnych perturbacji, które dzieją się z roku na rok, jesteśmy w stanie współpracować i pracować razem i do zobaczenia na pewno w przyszłym roku i nie obiecuję, że pojawię się patrząc na to, jak los bywa chytry i okrutny.
Thank you very much for these words. Is there someone else from our jury who would like to say also some few words? Pani docent.
Pani docent może.
Nie, jestem zachwycona sesją.
Chciałem podziękować po prostu, że chce Wam się, słowo się chce. Fajnie, że się... It's nice to have some people from outside our country. Great friends that you managed and you made this I hope you enjoy country and the region here.
Yeah, it's really fun.
Yeah, so we hope that you enjoy it. And to my Polish students, thank you very much again for being here. And the number of abstracts is, I think, it's increasing with each year. And the topics are quite different. I mean, you know, we have all very different topics. I'm really happy about it, you know. And keep doing that, keep improving. And this is a wonderful opportunity to speak publicly. You have to learn this as well because you want other people to know about your studies. Yeah, and one of the ways of propagating this results are through public speech, not only through manuscripts, but when you go with your preliminary results, you have to speak. So please improving your presenting skills further. Thank you very much.
Thank you very much again. So I think that's the end for today, and I'd like to cordially invite you for the decoration and closing ceremony of the SIMC 2025 conference, which will be held in A3 Hall on the 9th of May at 5 p.m. On the behalf of the Student Scientific Society, I'd like to thank you all for your participation in this session. Thank you very much. And may I switch to the Polish? Również chciałam bardzo podziękować szanownemu jury za przybycie, w szczególności pani docent, że tutaj do nas dzisiaj dojechała z tak daleka i jeszcze była w stanie w aucie oceniać tę prezentację. Naprawdę jest pani docent niesamowita. Również panu docentowi za jak zwykle wspaniałe przygotowanie uczestników do sesji i również ocenianie i tak jak pan profesor Krzyk powiedział, Agnieszce oraz Michałowi za przybycie do nas. Bardzo dziękuję.
No my dziękujemy wam organizatorom, żeście nas tutaj zaprosili, ugościli i
wiemy, jaka jest ciężka praca.
no tak, i podoba mi się tu bardziej niż w sali WCK, bo jest tu fajnie i jest fajna klimatyzacja.
Czyli do następnego razu.
Tak. No.
Dziękujemy bardzo jeszcze raz. Również weźmiemy wszelkie jakieś takie uwagi na przyszły rok, w szczególności nazwę sesji, żeby się nazywała Anesthesiology, Intensive Care and Emergency Medicine.
Zauważyłem, że pani powiedziała inaczej.
Dobrze. Bardzo dziękujemy i chcielibyśmy jeszcze Was wszystkich tutaj serdecznie zaprosić właśnie na imprezę w piątek. Carlos from SIMC, DSO.
Also, we want to invite our friends from Serbia for this party. Friday.
Thank you very much.